Welcome, everybody. We are so excited to have you here today. My name is Shruti Kothari, and I will be your moderator for today. We have an incredible event planned. We had over 500 people register for this event, which is incredible, just the amount of passion for this topic. And wanted to let you all know that Industry Initiatives at Blue Shield of California is hosting this event. And what we do is we work to move healthcare transformation through policy and also industry collaboration and alignment. And what you'll see in the chat dropped in is a link to our website. You can subscribe to our newsletter where you can find out about other webinars that we host like this one. We also do in-person events for any folks who are on the line that are coming to health in a few weeks. We will be throwing an in-person event there that we'd love to see you at. And we also do publications. And so we want you to keep in touch with us and so we can share all the things with you. So the panelists, if you can come on to the virtual stage. Hey, welcome everybody. So first things first, you all have tremendous backgrounds and I could not do it justice trying to give you all introductions. So I'm going to let you speak in your own words and introduce yourself. So Patrice, why don't we start with you?
Thank you so much. Really pleased to be here with everyone today. I'm Patrice Bergman. I'm the Vice President and General Manager of Blue Shield's individual and family business. Blue Shield is a California-based statewide health plan. We serve across all segments, and we proudly serve nearly 5 million Californians in just about every zip code and corner of the state. So you could say we have a lot of skin in the game for this conversation. This work is tied to our mission, which is to create healthcare that is meaningful to our family and friends. And that requires us to look across the entire ecosystem for how to incorporate social needs into healthcare better. When we think about our family, our friends, our households, regardless of which door folks enter, everyone has a universal need. And in our homes, many of us are accessing healthcare through different doors, right? You may have an adult who is covered by an employer-provided plan, a grandparent under a Medicare plan, perhaps a young individual for the first time buying their own individual marketplace plan, and maybe other parents or children who are covered by Medicaid. This is a very dynamic and transitional audience here that is flowing in and out between these business segments, how we structure the business. And so even now, when we are going through big transitions for Medicaid members into IFP, these transitions are even heightened. There are significant inconsistencies for members between these plans, and the need is consistent across all of them. And I would say I'm here to represent the commercial interests, especially where I think we're further behind the curve because one, funding, and two, I think we falsely equated individually purchased plans and commercially funded plans with housing security and transportation and ability to put food on the table. So the good news is we're not starting at zero. I'm really looking forward to the conversation today to learn how we work together.
Thank you for being here. Dominique, why don't we go to you?
First and foremost, thank you to the team over at Blue Shield of California for inviting Health Leads and myself to come and talk. My name is Dominique Morgan. I'm the Chief Operating Officer for Health Leads. We are a national nonprofit, and so we do work across the country, and our focus is healthy communities. And it's focused on health. And specifically, we look at health and health equity through the lens of sort of racial health inequities, and what have those racial health inequity, where can we alleviate some of the systemic issues that come up and then permeate through the healthcare, health systems, and in health outcomes. And so we work across a multitude of different areas, starting from on the ground with communities, with community-based organizations, less so in a direct service providing aspect, but more in a backbone aspect where we are providing a lot of support, whether it be in how to raise funds or support in sitting in the intersection between community, public health, and healthcare system. Like we like to say that we can translate across many areas in order to get to kind of healthier outcomes. We also do a lot of work on the policy side. And so where we look at kind of how do we interject and influence the community voice as policymakers are working through changes either to Medicaid and programs like this, or in other areas to represent kind of community and patient, so to speak, or person, community-based person in policy. Our mission, again, is to really help elevate the needs of underserved communities and really to drive home health. And so, again, I'm also really excited to be part of this conversation and to share some of the things that we're both doing and seeing in California, but also some of the learnings that we have from participating in programs similar to this in other parts of the country. Matter of fact, I'm sitting in New York right now and just participated in a conversation about where they are in sort of their DSRIP 1115 waiver journey and what are some of the next steps. And so really excited to share what some of the things that we've seen and learned and best practices, and also just things that we hope to come out of the CalAIM work. So thank you for having me.
Yes, we're very grateful to have you join this conversation, Dominique. Francisco, how about you next?
Hello, everyone. Again, thank you for inviting me to this conversation. I'm Francisco Silva, CEO of the California Primary Care Association. We represent the community health centers in the state of California, which represents over 1,300 sites throughout the state, serving over 7.4 million Californians, a third of which are California Medi-Cal patients. And I think with respect to this conversation, what's really important to know that gives a different context is that health centers were born out of the social justice civil rights movement. So many times, most were addressing social needs already, perhaps not as comprehensively, but addressing a specific need in a community. And because of that, I think we come to this conversation having been thinking about it for quite some time, but obviously having a major payer like Medi-Cal invest really does create real opportunities, of course, real challenges. So happy to dive into that conversation of where we can work together to address the social needs of our community.
Amazing. Thank you for being here. CPCA has a special spot in my heart because the very first virtual panel I did in 2020 for industry initiatives, Andy Martinez from CPCA said yes. And so she's my first speaker that I got.
Well, I hope to fill those big shoes that Andy had.
Oh, yes, you definitely are, Francisco. All right, Dr. Soni.
Yes, hello, I'm Monica Soni, really pleased to be with everyone today. I'm the Chief Medical Officer at Covered California, and I'm a primary care doc myself. I'll tell a little bit about Covered California. I think the comments from Patrice and Francisco really resonate. Covered California is our state-based exchange. We currently cover over 1.7 million individuals and then additional folks in small business. And I agree with the comments, right? The industry is at different stages of sophistication. Covered California from its inception has in its mission statement talked about reducing disparities and improving health. And I think the truth is that we falsely silo some of these pieces of health and wellness. The truth is that I as a primary care provider never said, oh, don't tell me about that housing challenge, or, oh, I don't want to talk about your transportation challenges. The conversation has always been fluid. As I'm thinking about what helps people live longer and live better, it encompasses all of those pieces. How successful have we been at being comprehensive, systematic, and closing gaps? I think that's a conversation for us all to have today, but does it belong in the space agnostic to line of business? 100% you will hear that from us, and that's very much our philosophy at Covered California. And I agree to continue to be in alignment with our other public purchasers. Medi-Cal, and certainly, our other sister organization, CalPERS, is really part of our core vision as well. So I think we're happy to ride some coattails and happy to be trailblazers in some other spaces.
Thank you for being here today, Dr. Sonny. Really appreciate your time. And so I wasn't lying to all of you in the audience. We have an incredible panel. You've heard the backgrounds, a little bit about what their organizations do. But to really kick us off in this conversation, and again, remember, as you have questions that come up, please do submit them in the Q&A box because we'll be getting to them later. But a few of you mentioned CalAIM. And so, this really is a huge step forward in connecting health and social services. It's relatively in its early stages, and there are many opportunities to learn and improve. So let's talk about that a little bit. Can you speak about the implementation a little bit more of CalAIM? And from your perspective, what are some of the real successes we've seen, and what are some of the challenges? And what do you think is sort of needed to meet those challenges? So Francisco, why don't we start with you?
Thank you for that. I think from a success perspective, investing in integrating social determinants of health component into healthcare itself is a success. To have a major payer like Medicaid, for a state like California to say this is part of the whole person care, I think in itself brings success because it drives changes in the healthcare delivery system and in the broader community. Just to give a few examples of that, it's forced partnerships and conversations about how do we do screening effectively. It's something we've been thinking about it for a very long time, and have a tool that we worked on called Prepare to have a systemic way to assess that. But now, because of CalAIM driving this and driving the payers and the entire delivery system and community-based organizations, we're having to think about collaborating together. The development of codes so we can, in our EHR, systematically screen for social determinants of health and then refer is critical. The other success is the building of the networks. And I know we're at the beginning stages of it, but one of the challenges has been for a long time is even if you do screen and identify a need and an urgent need for one of your patients, but if you can't refer them, and if you can't refer them quickly, there is an element of get identified a problem and I can't do anything about it. And it's been a major frustration and still a major challenge. But CalAIM and that driving force is forcing us in that direction. And do you want me to dive into challenges also?
Yeah, that'd be great.
And I think that also highlights a major challenge is that right now, CalAIM is focused on, at least from our perspective, on ECM and building out the community support network and actually paying using Medicaid dollars for community supports. It's a huge success in itself. But now the challenge is it's very limited. And for all our patients, we're trying to assess their needs and implementing those tools to address and screen for all their needs and refer them. But the program right now is limited in scope in terms of which patients qualify and then which referrals, where you can refer them to make sure they have those services. So that's still a major challenge. And there's major plan variability at this stage still. From one community to the next in terms of how they're implementing the program, how burdensome it is to be a participating provider. There's variability across the state, and that's a challenge we need to tackle. And then back to the data piece. The data is a challenge with respect to real-time assessments when you're seeing a patient. Whether they're currently participating in ECM, whether they're receiving community supports already, and the interchange of data between the plans, the providers, the ECM providers is still very challenging from a primary care perspective and also from a participant in the program.
Thank you. Dominica, would love to hear your thoughts in the health leads perspective.
Yeah. I think, first of all, you asked about successes, and I'll say the first successes that we're having this conversation, like is on the table. As I've spent about 15 or 20 years in value-based care and running ACOs and pop health. Matter of fact, I started my career at KP in Northern California. So I've been in a lot of different spaces, and then went on the other side of the country and was in Boston leading Pioneer ACO for Steward Healthcare. And what was consistently true, and have sort of gone on and have seen multiple iterations, both on the Medicaid, on the commercial, and also on the Medicare side, around how do we do this, right? And what has consistently been a factor and a challenge is actually the social component, which is the majority of someone's day, life, and their whole personhood. You know, the healthcare part is just a small snippet, right? Yes, it has huge impacts and factors, but when the larger thing is actually the thing that has the gap, or where it's out of whack, that's going to amplify. And that's what we see, right? We see in the data that people are 3 times more expensive if they have a mental health and behavioral health diagnosis, et cetera, et cetera. And so the success is that there's an acknowledgement that in order to drive health outcomes and also to decrease costs, let's be clear, right? We have to deal with the things that aren't necessarily that weren't naturally associated with health. While that's a success, it's also a challenge. And let me tell you why it's the challenge. The challenge is that the healthcare institution was set up to support healthcare. It wasn't necessarily set up to support the totality of someone's health outcomes that are tied to the things that aren't necessarily what we expertly do inside of 4 walls, right? And I see Dr. Sonny shaking her head, because every primary care doctor has felt this, like, time and time again, because it's not for lack of desire, but the mechanisms and the subsequent supports, both financially, both from a systems perspective, both from an acknowledgement of value. Not just value because but value that says, we know that this activity, you calling the social worker, you calling the housing unit, you doctor, you MA, whomever, is a valuable exercise. That's new. I mean, new it's in the last 5 to 10 years, depending on where you are in the country, right? And so, great, the successes we've acknowledged. The challenge of that is that we can't do it alone. Healthcare can't build it. It is not, it's actually already happening, right? And I think, Francisco, you highlighted very early on that, community health centers have come from a social justice perspective and a health justice perspective, and have that social component are tied to them. And so we have to use this time and structure programs in a way that actually amplify things that are already working, but they may only be working in a county. Great example is the 211 San Diego CRN. That's actually some of the work that we get to do at Health Leads, where we provide some backbone support for them, and also are looking to help amplify what they're doing. Now, what's really cool about them, it's an open source CRN, right? There are CRNs cropping up all over the place that are tied to who knew who and who decided to pay in to play in the system. And what we don't want to do is we don't want those community-based organizations and community organizers and others who are on the ground trying to really close gaps in a very meaningful way and know their community better than we do, right? We don't want to create barriers to them being able to also throw their hat in the ring, right? And so as we look at the ECM program and that kind of thing, it's a great start. But part of what I think is the ongoing challenge is that in the design was designed from a very healthcare delivery system centric perspective, right? And it's going to need some tweaking in order to include more of the community component, in order for us to really see the really leapfrog wins that we're really looking for, that is centered on health, not just healthcare.
Yeah. I love it. Your passion shines through when you speak about this. So, And a few folks on this call have mentioned, health-related social needs are they're not limited to Medicaid populations, which is like that old throw it in the trash sort of thinking. And so as we look forward and we're seeing increased momentum to address social needs across all lines of business, really, and for all populations. Dr. Soni and Patrice, can you speak a little bit more about how your organizations are thinking about that, how you're addressing health-related social needs outside of Medicaid, and where exactly do you see the gaps in opportunities? So maybe Dr. Soni, we'll start with you.
Thank you. And I think what's lovely is actually Patrice and I really are in parallel spaces doing the same work on the exchange for the individual market. So I hope what you'll hear is a lot of synergy between the work. Let me just reiterate what you just brought up, which is this is not a situation where we can continue to other, right? It's not like that population over there or those people over there. There was an article that just hit my inbox, I think today or yesterday, that showed that in LA County, 1 million households are food insecure, up from last year. That's not just Medicaid, right? That is all of us. That's actually our entire community. And it's absolutely our covered California enrollees. We know that our population is extremely price sensitive to very small changes. Why? Because folks are living on the margin and making choices about, do I actually decide to have coverage or do I invest in something else that's important to my family and to my life? So this is something that we are thinking about all of the time. I really resonate. Absolutely. I was vigorously nodding earlier because I do think this is hard work to begin to do when our structures are really set up in a particular kind of way. So I'll share a little bit about, we have a contract requirement right now. We were happy to be, I think, on the cutting edge of the HEDIS social needs screening measure, which is really, to Francisco's point, making sure that screening is happening, and importantly, that there's an intervention in a timely manner. Now, we know that there are enormous challenges in that. We didn't expect that we were going to put that in our contract and solve problems. I think it was a signaling to start investing in this work outside of just the Medicaid space. And we have a deep appreciation at Covered California that innovation takes a little bit of failure too. So let's try some things, let's learn, let's iterate, let's get better. We see that there's work happening at Medicaid, some of which we can replicate, some of it we can't. There's work happening at Medicare, commercials, no exception. So that is really the spirit of what you saw in terms of our contract language. In terms of the challenges, again, I won't be redundant to what's been shared here, but I do think we know that sometimes screening becomes a destination, right? It becomes a box checking exercise that occurs. And we have redundant, duplicative, wasteful activity that doesn't actually close the gaps or make people's lives better or address the health outcomes that we want them to be addressed. So that is a worry, of course, that I have. The capacity, as we've already talked about, not only do we actually have the roads between our organizations and the community-based organizations that know how to do this better than the rest of us. So are the roads there? And then is the capacity actually there as we start to ramp up? I think we already know the answer is no. Just let's be clear, right, 1 million households in Los Angeles are food insecure. So no, we must not have the capacity there. And then how do you have different and creative ways of funds flow, right, that isn't overly medicalized, that doesn't kind of keep it in this space? That I think is complicated work for us all to do and to be advocating for. And I think we are trying to think about at Covered California, what do population health investments look like that are a little bit more creative, that are out of the box, that are willing to experiment in the spirit of knowing that this work, touches all of us. So I think that's where we are. It's an acknowledgement and ownership, collaboration with our partners, and realizing we're probably not going to get it right the first time, but we're here to attempt it because it's so critical. To the earlier point, 80+%, right, of what keeps people healthy is not what happens within the walls of my primary care office. It's in all of the other spaces, and so we have to lean in there.
Appreciate that, Dr. Soni. Folks on the line that are saying they can't hear Dr. Soni, we did a little testing on the sound earlier. Dr. Soni has done her best to put her outputs at the highest point on her computer. So I would just suggest, if you can't hear Dr. Soni, just turn up the volume on your computer when she comes on, because she's saying amazing things and you should listen to her.
I'm sorry, no one has ever told me I'm quiet before, so I'm struggling with this feedback.
As a fellow loud person, I understand. And the good news is that the recording that will come out to you will have closed captions. So for good news on a recording coming. Patrice, how about you? How would you answer that question?
Well, you can tell that Dr. and Tony are in lockstep together. As I mentioned earlier, given the frequent movement of members right now between ACA and Medicaid, it's really imperative that qualified health plans build these muscles to address social needs in the individual market in particular. And I really appreciate Covered California's thoughtful leadership to help us really focus our efforts, to expand screening, to not just screen, but make sure that we're also getting folks support and referrals to care, and then to minimize these disruptions that happen when people are moving back and forth between these different systems with really different experiences. We're engaged in building a lot of these pieces out. Screening isn't the end all be all, as Dr. Soni said, but that said, it is a really critical first point. And Blue Shield in particular identified that when we looked at our individual members who self-selected to complete a health risk assessment, 13% of them were identified as having a need. So we know it works, but the actual numbers of folks, especially in the commercial space, who are screening is still pretty negligible. So we're trying to figure out what are those touch points in the member life cycle that make sense to connect. First priority is certainly aligns with Francisco's messages about standardizing primary care as that first point of contact for screening. I think this is also an opportunity really to shift not only actions and behaviors of providers, but also to shift an expectation of members to normalize what is standard and expected in the course of a health visit. So when we're asking these questions to help assess needs, it's just as common as expected as I'm going to get my blood pressure taken, right? So helping the population understand, boy, this is an important thing to work on together. The second touch point we're building out for screening is onboarding. Makes sense, especially with all of these transitions happening. What that looks like is really helping shuttle our members through. So navigation and benefit education, provider selection, what is my out-of-pocket expectation, what are the benefits and services that are available to me? And we're really sensitive to that continuity of experience. This is a real concern because if you think about these very real ways that members are experiencing this support, let's use transportation vouchers as an example, right? That doesn't exist today in the ACA with the current limitations on funding. So we've got to build a bridge. Everyone here has already mentioned, right? We've got to really connect with community-based organizations to help us build that bridge, but we've got to be really careful to scale this thoughtfully. One, to make sure that we've got the funding to support these organizations who are doing yeoman's efforts, and two, to really make sure that we are creating space for them with, what could be just significant volumes, right? So the capacity concerns. The last area where we're looking at enhancing touch points with our members is actually in the care delivery process when our care management teams are interacting with members, doing screenings then and referrals. And that's a great segue over to, okay, you screened. Now what the heck are you going to do about it? I'm really excited because Blue Shield is launching a new statewide referral platform that is tied to our proprietary Care Connect complex care system. And the idea is to help expand and accelerate referrals to support services. This is the same system that supporting members with the most complex care needs will all now also be able to support members who are experiencing social needs support. And what I'm especially proud of with this work is that this is designed to be a closed loop referral process. So not only expanding referrals and connecting folks to services, but really circling back to make sure that needs were met. So it's new, and I'm really excited about the possibilities. But obviously, we are early days training wheels on this, and I'm really looking forward to the opportunity to learn from others on best practices we should be incorporating.
Thank you, Patrice. Appreciate that. Okay, so we're nearing up on our last question. So that just means for folks in the audience, submit your Q&A because we do want to, we're gonna save a good chunk of time at the end to answer them. So submit those if you haven't already done so. But to our panelists, a lot has been discussed today. And so I would love to hear your own reflections on your own experiences, along with some of the conversation today on what you think is the most critical next step that we could take to really transform and support change that improves access to social services and advances community health and equity. So who needs to be involved, and what specific actions should we be taking to ensure that this progress is made? Let's start with you, Dominique.
Thank you. So great question. I've been thinking about this one for a minute, and I did mention I was fortunate enough to be sort of in a similar conversation around what's happening in New York. I've spent some time in Boston also, as they are on their own journey, and I think a couple of consistent themes. Obviously, I'm gonna keep harping on this one thing, which is community. And not just community involvement and engagement in terms of how do we ensure that there's resources to help support the folks who are in the community to do it, but actually how's community involved in the design, right? Is it we often design things for as opposed to designing with. And that's actually kind of one of our pillars, right? Is that not just elevating community voice, but being with community and bringing community to the same tables as policy and public health and healthcare systems in order to better design solutions, because they can tell us better than we can tell them, right? And then we can add other pieces to it and we can get there together. The other thing that I think is really important for us to consider, and I think this might get to a little bit of what Francisco was talking about before, is that we can't design things monolithically, but we tend to, right? And we don't account for the fact that people are multifaceted in who they are, right? They're not just, that intersectional piece is incredibly important to account for. Someone could both be, not a native English speaker and disabled and of color, right? And those intersectionalities actually have like a triple to 400 to 500% impact on their likelihood of being food insecure, housing insecure, have mental behavioral health, and have financial issues all wrapped up in it. And we will sometimes do all the right things, and that we'll screen and we'll say, okay, do you have access to healthcare? And we'll get them attached to our primary care provider. And then we say, you qualify for the housing program, but not the food program because you're in the housing program. Right. And it's like, but I'm hungry and I want to have a roof over my head. Like, help me out here kind of thing. And by the way, can you make sure that that's in Armenian? Because I don't speak English, right? And so like, we aren't necessarily thinking about it's so interesting to me because we also love to talk about that pyramid, and we always like, we want to do the most for the people who are at the highest point in the pyramid. And then we don't realize that typically people who are in the highest point in the pyramid, the other levels of the pyramid have failed because we aren't accounting for the intersectionality of it, right? We're not accounting for, they're diabetic and they're complex comorbid, okay. Like at this point, we're like, okay, that's old hat. They're complex comorbid and they have mental behavioral issues and they have social determinant issues. And we'll design programs around, let's just focus on the social determinant piece. But if you qualify for the ECM program, you don't qualify for the 1915C program. I saw that in the policy, right? I don't know what that means in terms of the impact in California. And I'm sure somebody else on this call does. But that's, to me, like red flag. If I was sitting in the room, I'd be like, okay, so what are we exactly saying? Are we saying that somebody who's already been identified as homeless and housing insecure and also needs a care manager and a navigator has to make a decision. And do we think that they have the capacity to understand the impact of, in a moment, somebody saying, pick one, and not knowing the implications, right? As opposed to saying, well, give it all. Like, what if we double down and say you need both? Because if you came up through the screening mechanisms to say you qualify for ECM and you're already qualified for this other program, doesn't that mean that maybe we missed the boat somewhere and maybe the combination of the two is actually what you need? And I know I'm being simplistic, so I'm not trying to be, but I guess the intersectional component of who people are, especially if we say that our programs are supposed to be our whole person centric, need to account for that people are not one thing. They're not one condition, and they don't typically have just one challenge. They typically have a multitude of challenges. Now, what is very true, especially as we think about this from a perspective of health equity, is that we have groups of people who are disproportionately affected by a multitude of issues. And that's not because of the issues, or it's not because of their condition type, but it's because some of the historical and systemic issues that have been related to how they phenotypically show up, right, in terms of their race and ethnicity. And that's something that we can talk through and deal with. And that's actually the conversations we love to have. And it's also the work that we really love to do at Health Leads. And so I'm excited for us to have that conversation. The other thing I just want to add to is that having done this for 15 and 20 years, and I know a whole lot of people who can say that, right? Seriously, there's a Pareto graph. It's a Pareto diagram when we look at which means whatever we construct today is going to have to look different 5 years from now, because ultimately what we end up doing is we end up finding the low-hanging fruit, and then the next level becomes the low-hanging fruit. We have to continue to recognize that there has to be evolution, not just because people are changing, not because technology and informatics and analytics and AI is changing, but the needs of individuals will become more and more and more and more complex, and those will be the ones who are driving they will be the outliers that are driving the outcomes, not just costs, but overarching health outcomes. And because of that, we'll need to also evolve with it. And so there has to be some accounting for that in terms of what we design for later, not just what we're designing for now.
Yeah.
Thanks.
Couldn't agree with you more, Dominique. Francisco, how about you? What are some of your thoughts?
Well, I think I want to reflect back on what Dominic said initially, that I didn't realize I was struggling with until she said it, which is we're asking, at least in the CalAIM perspective, and many of us around this panel, we're asking healthcare to solve this broader issue beyond the medical side that many of us have been used to solving. And because of that, I think we can run into the same problems that we've ran into on the medical side. And I think that goes to the question that you asked, who should be at the table in designing this? And I think we need to invite others, because even now, right, we've asked the health plans to develop the program and develop a network. The state has. And in doing so, we end up with variability. And so if you're a provider on the ground, whether you're a community-based organization or a primary care provider or a health center, you're like, okay, with Blue Shield, I'm going to do it this way. Medi-Cal wants me to do it this other way. For my non-insured, I'm going to do it this way. For my county program, I'm going to do it this way. And ultimately, that ends up being one of the biggest hurdles and challenges, is that you don't have standardization, how you're doing assessments, how you're doing referrals, how you're paying for it. Like, I can use my community health worker. I got to use a grant funded if I want to do it outside of Medicaid. And if I want to do it in Medicaid, I can only do it for ECM. And so you end up with all these challenges. That's just one good example that we struggled with. So to your question, Shruti, maybe it's we need to make sure we include others and make sure we ask if it's the state that's driving the program, to say there's certain things, state, that you should keep. We want standardization. We don't want variability. And there's other things that they have to be community informed and community driven, because healthcare is very local, right? It's going to look different in every community. and different parts of the community are going to get involved. Some counties are very engaged and some counties are more hands-off. So it may look different in each area. So it's kind of a mix of both. So from who's at the table, we need to be very intentional about who's at the table. And then in terms of impact, I think the data is important because at least for those of us in the healthcare space, we're being asked to do that in every other way. So I think the data is going to be critical in having the resources and the infrastructure for that, and investments in that, and to build that capacity, and whether it's training of our staff in that space or the infrastructure for us to be able to really implement.
That was Francisco. That's like music to my ears as I lead a team that I mentioned, industry initiatives. That's all about focusing on industry alignment. And so when we look at healthcare transformation in general and what prevents the scaling of it is fragmentation. And that was just a beautiful example that you had of all the different folks in the ecosystem, and perhaps not everyone's at the table designing the system so we can actually scale them. And what a great handoff to Patrice from the health plan perspective.
Well, I fear you're going to hear a lot of the same themes in my feedback. Collaboration, I think, is key to this with every player, including community, to Dominique's point, right? Payers and providers and regulators and community-based organization and community members, right? What I'm heartened by is that California is I think is unique in our very collaborative approach with varied stakeholders. And we have demonstrated experience. DHCS and Covered California and CalPERS most recently successfully modeled the way to work together in quality transformation to do two things, right? One, I think, is on focus and standardization of measures, which Francisco mentioned. And then additionally, starting small, testing and learning from pilots that we then can scale for maximum impact. So I have a ton to learn. I've learned so much today. I really appreciate being part of the conversation, but I'm heartened that one, we have an environment that already is oriented to work together, and two, it says something to me that we're all saying the same thing, right? Like, we've got to come together, we got to work it out, people, and we've got to kind of standardize. And I'd like to use a Steve Jobs quote, go deeper, right? Focus on fewer and go broader, and then build from there.
That's awesome. Thank you, Patrice. And Dr. Soni.
Yes. Okay. I'm trying to be tech support for myself. Tell me if this is better. I'm really using my big voice.
You didn't get your MD and an IT?
So let me, maybe I will just start by sharing a story, which is that it was only after I was a practicing clinician and had actually read the definition of what housing insecure was that I realized for most of my upbringing, I had been housing insecure. So I spent a lot of time reflecting back on that. And I was a Harvard undergrad, and still my family was housing insecure. There were moments where my younger sister and my mom were living in a motel and like always at risk of eviction. I mean, like, that was my reality. And I think, again, to this point of othering and stigma, like, you have no idea, right, without asking what somebody might be experiencing and the implications and impact of that. I'll also, though, say I'm not so sure that had someone asked me and put it in my medical record that I would have wanted that to follow me for the rest of my life. And so I do think there's sometimes we didn't talk about it much today, but data exchange as being the solution for it and the way to get rid of some of the redundancy in the system. But I worry a bit about that. There are places where it belongs and there are places where it doesn't belong. And I don't want us to be taking shortcuts when actually you do need to have accurate, in the moment assessment of what somebody may be facing. So I want us to be thoughtful about how do we use all of the technology and tools that are now at our fingertips, but also appreciate, and this is where, of course, the co-creation or following, right, of community and folks that actually are having those lived experiences, which is many, right? It's not just some communities and some experiences, as I said, I'm probably I was denominator eligible at some point in time in my life, right? Like let those folks tell us how we should be doing this work and when they want to be linked and to whom, versus again, taking some shortcuts, which I think make us maybe make the job easier in the moment, but isn't the kind of iterative, thoughtful growth mindset that Dominic talked about earlier, which is really what we're striving for in this space. And I hope you could hear me. How tragic if you couldn't hear me.
Cross the fingers. But yes, I like the snaps, Dominique, because that is so true. Everything you said. Thank you for sharing your story too. I love that because as we see you today, we can maybe assume certain things about you. And so having that background really just calls to attention some really important things. And one thing that you mentioned with advocating for the right sort of use of data exchange for folks on the line who are interested in that and making sure the way that's set up is in a way that really is supportive to our populations. There is a coalition called Connecting for Better Health, where we are advocating for data exchange. And what does that mean and how does that look like in implementation? So in the chat, we'll drop a link to that coalition. Would love to have you join the coalition if you're not a part of that coalition yet. Awesome. So now we're going to the Q&A part, which is always my favorite part. I am using my phone because I am reading your questions. I promise I'm not texting anybody because there's nobody I'd rather be with than all of you guys. So, all right, first question. Accountability to the communities we serve can be very challenging to measure. How do we develop public accountability for most aspirational goals of improving access to advanced team-based primary care and broad care services? So Francisco, do you want to get us started with that one?
Sure. Thank you for the question. And I say thank you because it is a critical thing to look at. It's not just about having coverage. And I know we know that challenge on the medical side, and we're still struggling with how do you make sure and how do you measure that you actually have meaningful access, and is it timely? And I think part of it is making sure that the data is there for us to be able to assess that, but also the type of data and who we're asking. And that means back to the table conversation, who's at the table to assess the accountability? Is it cross-sectional? Are we looking at the communities that we're trying to serve and including them in the assessment? I think those are all critical things to look at. And we've struggled with that on the medical side, right? So maybe this is an opportunity to do it different. And measure it differently. So I welcome others and their input, but the data will be critical. Make sure you have a diverse input of the data, not just numbers, but anecdotal surveys to look at the community, make sure it's meaningful beyond just access.
Awesome. Thanks, Francisco. Any others have anything to add before we move on to the next audience question? All right, you said it so well, Francisco. And at first, I thought you said diapers instead of diverse. For folks on the line, Francisco has a baby at home. So
Changing diapers in the morning. And that's a tough question, right? So it's how do you solve it? I think we're still struggling with it.
Yeah. It is very much a tough question, and more reason for the industry cross collaboration, right? And thinking through a lot of this and the different aspects of it. All right, second question. What policies can be put in place to support our community-based organizations to be able to meet the needs of patients once identified? Often we talk about referral networks and community resource platforms as a solution, but I'm concerned that we are not also considering how to support the community. How to support the community-based organizations to be able to support the influx of need given already limited resources. So Dominique, I think probably a good question for you.
Thanks. So I agree that CRNs are a good necessary part of the journey as it relates to connecting community to communities and community-based organizations that can help solve those needs. But I will say the financial, like the biggest piece is how do they financially do this? And like a lot of our work is around how do we help CBOs remain sustainable, viable, and continue, like keep pushing their mission forward. And there's only so many grants that we can apply for, and there's only so much fundraising, right? And I think this gets back to this recurring theme of the table, like and bringing communities to the table. I will say, great example. That worked and didn't work, right? In Boston, how they chose to use, or Massachusetts, how they chose to use the 1115 waiver was to incent and to essentially force MCOs, so managed care organizations who are opting into the ACO, to have to participate, to have partner CPs. Not that different than some of the stuff that we're talking about here. And one of the metrics that they used wasn't just like referrals and all the rest of that stuff, but how much of the dollar was being given to those community-based organizations. Now, and in the first 2 years of the district program, you saw a lot of dollars going to community-based organizations who were already there, but were struggling, right? And so this was an opportunity for them. And they brought in, and conversely, what also needed to happen, and I think Mass Health was really smart about this, which was to say that those community-based organizations needed technical assistance to be able to gird their business acumen, right? Especially operating in a kind of healthcare business world, right? And so they also gave them dollars to help support their infrastructure, which even outside of, the district program is now in its debuting its second iteration in a different way. Those skill sets are lasting, right? What those community-based organizations now have is sort of a lasting infrastructure on how to work with healthcare, how to build a healthcare system, how to, think in terms of resource in and resource out kind of thing, which is slightly different than they were before. So that's a good thing. The bad thing was because it looked like the pot was the managed care organization's pot that the dollars were being taken out of. You had providers who were like, provider organizations, I should say, who were like, we could build this and keep that dollar in-house versus partner and have the dollar be out in the community, right? And so I think there's definitely learnings now, right? Like there's like, wait, did we do that the right way? Kind of thing. But I think what was important is the key takeaways is that some of the dollars have to flow to community in a structured way, right? And it has to be very meaningful, right? And it has to be, I would say there has to be a very open board or platform that makes the decision as to which community partners are part of which part of the ecosystem, because otherwise you run into the problems that you actually currently have, which is where those partnerships may X out people who are actually doing most of the meaningful work. And then the last thing I will say is the thing that we also have been saying, which is got to be able to measure the impact, both the impact of and that's not easy, but we have to be able to do it.
Yeah, absolutely. Definitely a common theme throughout our conversation today. Next question, Dr. Soni, for you, do you feel there is enough alignment between the different state efforts to bridge health and social care, such as between the data exchange framework, CalAIM, and Covered California's efforts? If not, why and how do we improve this alignment?
I think that there's been tremendous effort in this space. I'm new to Covered California, but there are folks I work with who have been here for 11 years, and they have said to me, it's unprecedented, the level of connection that we now have between DHCS, CalPERS, other folks. So for that, I think, yes, a lot to celebrate. And, do I have a, group chat with folks at both organizations? 100% I do, right? It's that level of connection. It's not all formal, it's informal thinking about the challenges, but there are still difficulties where we cannot be in alignment. And Patrice even talked about a little of it. Our legal structures are different. How we're governed is different. How dollars flow is different. That doesn't mean that we shouldn't keep trying. And I actually think the more that issues can be surfaced, from all angles, right? Can folks that are advocating for changes learn a little bit about our regulatory structure so you can help us make change from within? Can we learn a little bit about what the pain points are so we can actually take it up to our governing agencies? I think actually the transformative work that's happened in Medi-Cal around coverage for folks that are incarcerated, and that bridge is a good example, right? Something that everybody thought was impossible couldn't be overcome. It's not the way that Medi-Cal works, is now possible. So I do think that even though there are differences, we're not 100% in lockstep because of those structural challenges. Could it change in the future? 100%. It just takes us actually thinking about what the problem really is and being really surgical about what the solution is, not throwing our hands up, and also not doing the blame game, right? Like, we have dollars that flow a certain way. There are structures that were put in place a certain way. The policy is what the policy is. It doesn't mean it can't be changed. Let's think about it, but together, then I think we'll really get there.
Yeah, of that. Last question, because I've never ended a panel not on time. So the last question is, if we're looking to improve health outcomes through interventions and addressing social needs, what factors should we look at when introducing pilot programs without concrete sustainability? Dominique, let's go ahead and start with you.
Ooh, okay, I didn't think it was gonna go back.
Oh, sorry.
I was like, oh, Patrice got a hard one. My bad. You're asking what are the things we need to use to measure to.
Yes, when we look at introducing pilot programs, like what with when we think about sustainability, you know, what factors should we be including in those pilot programs?
Yeah, I think first of all, we can't shoot the moon, and we have to recognize that things change over time, and so we have to be more. We've done this enough to know that we can be a bit realistic about what the beginnings of success looks like, to be able to say, yes, we want to infuse more things, as opposed to saying, well, did you save it? Did it, you know, impact infant mortality? That's not realistic in 6 months, right? Like, that's just like, and so being more realistic about what the measures of success are, and then honestly, again, because we're talking about community, we need to do a little bit better about the qualitative data, not just the quantitative data, like getting people in the room and finding out, like, okay, was this meaningful for you? Like, did this actually impact you? Did it make your life easier? Did it make you more likely to seek health care, or did you feel better about your health? Like, those things are actually important, because we know over time those things lead to the bigger metrics of the things that we can, like, you know, mortality, morbidity, outcomes, blah, blah, blah. And so, and I think the other piece is trust. When we talk about all community and instituting pilots, and we talk about systems and providers, like, we need to ask questions to see whether or not we're trusted, because when you're trusted, you're more you're more likely to be sought after, and you're more likely to be listened to, right? And that those are softer ones that are easy to sort of pull very quickly to be able to say whether or not some things that we're instituting actually make sense.
Yeah, that's beautifully said. And any other thoughts from anybody in the last few seconds? All right. So that is it for us today. Thank you so much to our panelists. Really wonderful discussion. And thank you to the audience for being here and engaging in this conversation with us, for the work that you do, because I know you're going to take this into your everyday kind of lives and implement some of the things that you've heard. We'd also love to hear from you. So definitely feel free to reach out anybody on this panel. You will get the recording. And other than that, I hope you sign up for our newsletter so we can see you again, both virtually and in person. All right. Thanks, everybody.
Thank you.
Thanks for guiding us.
Bye.